Hello everyone, this is Professor Harkirat Bal. Welcome back. This is our third and final part, the last part of substance-related and addictive disorders. So a quick recap. In previous parts, we talked about 1 through 5. We spent a lot of time on alcohol use disorders. And in this part, we'll finish our rest of the list, 6 through 10, and also non-substance use disorder. We will spend a lot of time on number 6, which is opioids use disorder, but the rest of them are going to be very quick, just like we did very quickly 2 through 5 in the previous lecture, okay? All right, so opioid use disorder is number 6. Take a look at the definition. It's going to look very, very similar to you, the one that we did 1 through 5 earlier. All right, so what is an opioid, first of all? Remember, these are your narcotics, your controlled drugs, hydrocodone, oxycodone, Percocet, Vicodin, OxyContin, morphine, tramadol, Dilaudid, codeine, fentanyl, heroin, methadone, your pain management drugs, right? So they all fall under opioid use disorder category. So these agents, they come from this lovely plant, if you will, from a milky secretion produced by the poppy flower seed. Opiates fits into the endorphin receptors. We do have these receptors. Actually, just like cannabis, we do have a natural morphine or heroin in our brain, beta endorphins, and that's where these agents fits and gives us that analgesic effect. And they are, all of them are actually seen as a depressant, right? They're going to slow down the respiration rate, cause sedation, and so forth. And we already talked about the examples. When we talk about opioid use disorders, it all comes back to how opioids interact with brain's receptor systems. There are 3 main opioid receptors we need to understand: mu, kappa, and delta. Under normal conditions, when you touch something painful, let's say hot surface, pain signal travel from your peripheral nerves, let's say on the fingertips, to the central nervous system and up to towards the brain, right, where you perceive pain. Now, when someone takes opioids, these drugs bind to these opioid receptors and block those pain signals. Now, that's the therapeutic effect. It's a normal physiology. We are just blocking the message from the fingertips all the way to the brain. That doesn't mean that we have eliminated the source of that pain, right? We just put a lid on it, pretty much, right? We act that we are not in pain, right? So that's normal physiology. But the same mechanism that gives us a pain relief also play a huge role in addiction. So let's break it down. With mu receptors, these are the most important in addiction. They give strong pain relief, but they also trigger euphoria, which is that sense that you feel high, right? That's the experience that people report. They're also responsible for that physical dependency and withdrawal symptoms from opioids. This is why mu receptors activation is the main driver of opioid use disorder. And also kappa receptor, which is your second receptor here, provides some pain relief and sedation, but they can also cause dysphoria. It's a feeling of unease or dissatisfaction. This can really influence how people experience opioids and whether they continue using them or not, because not everybody like that experience, right? Okay, now the third receptor is delta receptor, also help with analgesia, the pain management, but they can also lead to some other side effects such as hallucination and mood changes. The takeaway message here is that the same receptors that gives us effective pain control are the same ones that fuel those cravings, tolerance, and addiction. That's why opioid use disorder is so complex and it's really deeply tied to our brain chemistry. Okay, so I am not going to talk about opioid use disorder criteria because, as I mentioned earlier, it's going to be similar to your alcohol use disorder. Just follow that, just replace alcohol with opioids, and then you have the criteria, right? But I will spend some time on opioids intoxication and withdrawal. So anyways, let's talk about the intoxication. What happens when you take too much? Well, I think we all know this, right? What happens when your patient either intentionally or accidentally took too much narcotics? Well, in the beginning, you're going to feel good. So you see that initial euphoria, but very quickly you'll see some other, depressant symptoms, right? When we assess their eyes or pupils, we'll see constriction. I do have an image coming up in a second. And then we'll see overall drowsiness, slurred speech, impair memory, if you will, impairment, bradycardia, hypertension. We know all that. Well, here's a visual clue. Just remember blue. B for breathing. It's going to be shallow. We know that. Lips are going to be blue because of decreased oxygen. Everything's going to be slowed down, right? Patient is going to be unresponsive. And just take a look at the eyes. Here's your constricted pupil versus a dilator on the left side, right? So this is a good image to remember. And now opioids withdrawal is going to be the opposite. You may see, in the beginning, it's going to be more of a yawning, maybe some muscle aches and maybe runny nose and so forth. And then some severe symptoms can be nausea, vomiting, insomnia, anxiety, and so forth, right? This is an important slide. This is a scale that we use to assess for withdrawal from opioids. So the name of the scale is the clinical opiate withdrawal scale, COWS. Do not get confused with the SIVA that we did. It was the scale that we used to assess alcohol withdrawal, but this is for opiates disorder, okay, withdrawal scale. So there are 11 items. Please take a look at the items, restlessness and tremors, yawning, anxiety, and so forth. So just like we put our clients with the SIVA on a scale, remember, with the different scoring system for mild, moderate, severe, similar concept, different scale, of course. So you have a 5 to 12 mild and moderate and so forth. Here is a list of some of the options for non-pharmacological management for opioid use disorder, and we talked about them in a part 1. Make sure you go back and review these, please. Okay, so I do want to spend a good amount of time on medications for opioid use disorder. We have 3 options in front of us, and we'll talk about them one at a time. Okay, so the first agent on the list is buprenorphine. This is very interesting drug because it came into the market as one of the pain management agent, if you will. Then they realized that it does have a potential to help individuals suffering from opioid use disorders. So the way it works, the mechanism of action is it's actually a partial agonist with high affinity for the mu opioid receptors. What do I mean by that? Well, when you have very high affinity, that means that you are not going to allow any other agent to bind at those receptors because you're going to dominate. You have a high affinity for those receptors. So you're going to display other agonist agents from the receptors. And what are those other agonists? The one that we do not want. If the patient is using either heroin or fentanyl, let's say. So this medication will block the effect of opioids. It will also help with suppressing craving and withdrawal symptoms management. Now, when you start taking this medication, you are going to be physically dependent on this. However, the symptoms are not as problematic, or there's no behavior as you see with other harmful agents, such as heroin or fentanyl. As far as the formulations is concerned, it does come as either a film strip or a tablet, or even extended release sub-Q injections that can be given either weekly or monthly. It is classified as a Schedule 3, and it's also part of a REMS program. There is an option available to combine buprenorphine with naloxone, which is an opioid antagonist, and this combination helps to prevent individual from crushing the tablet and use that as either IV injections. So that's the main reason to add this. And when we add, not that you need to know this, FYI, the ratio for combination is a 4-to-1 ratio. That means you have a 2 milligram, let's say, well, if you have 4 milligram of buprenorphine, 1 milligram will be naloxone. That's a 4-to-1. But if you increase that from 4 to 8, you're increasing from 1 to 2, from 4 to 12, then 2 to 3. And if you're decreasing from 4 to 2, then naloxone will be decreased from 1 to 0.5. But on any given combination, the ratio is a 4-to-1. And we always assess for withdrawal using the scale that we just talked about, COWS, and we initiate when withdrawal symptoms are moderate to severe. At least the number has to be more than 8, about 8 to 12. That's your moderate to severe scale, right? In a mild withdrawal, it is often appropriate to begin behavioral interventions such as CBT or some other psychotherapy management modalities, right? So especially if you're not going to start medication at that time, then it's a good approach to manage those symptoms with non-pharmacological interventions. And always follow facility protocol when we initiate these agents. All right, well, second agent is methadone. It is a long-acting, it's a full opioid agonist and bind to mu opioid receptor, just like buprenorphine did. But remember, buprenorphine was a partial agonist, and this is a full. Just like our previous agent, this will also help with the craving for opioids and decrease that euphoric effect of opioid use. The individual is going to be physically dependent on methadone, but as I mentioned earlier, they do not have problematic behaviors as seen with other agents, for example, heroin or fentanyl. I know some people believe that how is it fair that you're just replacing one drug with the other. Well, I personally believe it's a good approach. At least we are telling them, hey, bring all those street medicine, if you will, the one that you're taking, give it to us, and we'll give you something that at least we know what you're taking. It's a cleaner, and we can monitor. We know exactly how much you're taking, and then we can do some workup and so forth. So overall, when you have a client on this methadone protocol, if you will, you see decreased opioid use, decrease all cause mortality from opioid use disorder, and decrease the risk of mortality from overdoses. So that's a good thing, right? It is heavily monitored, of course, and rightfully so. And you guys know that it's a Schedule II drug, and it can only be dispensed through federally regulated clinics, with some exceptions. And those exceptions are if the patient is in the hospital, let's say, and then we need to manage their pain, or we can give 3-day supply and so forth, sometimes even more. But anyways, it does come as either liquid or tablet, or some other forms as well. The few things about methadone is that we need to assess for drug interaction. There's a lot of interactions with different medications such as antibiotics and so forth, antiviral, antidepressant, and there's a concept of a QTC prolongation, and we always do baseline EKG and monitor them frequently, and just FYI, the treatment dose for methadone, if we are treating opioid use disorder, is much higher than if the patient was taking this for pain management. Example is for pain management, let's say the patient is taking 5 to 10 milligram per day, then the dosage for opioid use disorder is going to be higher, for example 60 to 80. Because the aim is to stabilize and control craving, and not just a pain management here, right? Okay, number 3 is naltrexone. We talked about this under alcohol use disorder, but very briefly. I'll remind you, it's an opioid antagonist. It will block the effect of opioids, right? It prevents dependency on opioids and reinforce abstinence. Naltrexone doesn't work in overdose situations. So if the patient has taken too much, this is not going to reverse the effect, right? We'll talk about overdose in a minute. So a client must be opioid free for 1 to 2 weeks and consider a naloxone challenge test if you believe that you might anticipate withdrawal, because that can be very dangerous. Usually, to be honest with you, my personal experience is the patients are very honest with you. They will tell you that no, I actually took the narcotics or whatever that substance is, opioids, yesterday or 2 days ago. They'll let you know, because they do not want to go through withdrawals anyways, right? So, but keep that in mind. If you're suspecting that, you can give them naloxone to challenge them that way, and we know it's going to be safe for them to take naltrexone, right? As I mentioned before, we use this for alcohol use disorder, and we prefer this if the patient has both alcohol use disorder and opioid use disorder. Then might as well start to treat both at the same time with one agent. All right, kill both birds with two birds with one stone, right? Okay, formulation once a daily PO, or it comes as a long-acting injection, which is once monthly. It's IM injection. One important concept I think we talked about under alcohol as well, that we need to hold naltrexone if the patient needs acute pain management. For example, if the patient is scheduled for surgery, we need to stop giving them naltrexone, because we do want them to get effect of that narcotic when they need it. And if the patient continues on naltrexone, then they will not be able to, we will not be able to manage their pain appropriately, right? Okay, so what do you do for opioid overdose? Well, naloxone, right? So do not get confused with naltrexone, right? These are two different agents. So the first thing we need to do is, if you are suspecting overdose, number one, stop that agent, and then we give naloxone and we manage the symptoms. It's a fast-acting medication. It will reverse the effect of opioid overdose, right? And it is opioid antagonist. Well, that makes sense. It's going to reverse the effect. That's antagonist, cannot be agonist, right? But it does have a short duration of action, 20 to 60 minutes. Like I'll say like a half an hour to an hour, right? So because it has half-life is such short, right? And then most of the opioids, as if you're taking methadone, it may have half-life of a day or so, like a 24 plus hours. Heroin is going to be about 2 to 6 hours or so. So this means that opioid toxicity can come back after the naloxone effect wears off. So we need to monitor, to reassess, make sure you keep assessing, and then perhaps we need to repeat the dose of naloxone, right? So if you give too much, let's say, of naloxone, since it has a short half-life, any withdrawal that will be caused by naloxone is going to usually resolve on its own within 1 to 2 hours or so. So just keep that in mind. But monitor them very very closely though. And of course, it comes in a different form as well: sub-Q, IM, IV, or even nasal spray. Since opioid use disorder is such an epidemic in our country right now, and we do have this, a policy or regulation, whatever you want to call that, at least in California, that most government buildings, offices, agencies, and school system are supposed to carry a reversal agent and naloxone, right? So huge need for primary prevention on this topic, by the way. Anyways, here's the treatment summary for opioid use disorder, so please take a look at it. All right, well, so that was number 6, opioid use disorder. Number 7 is our sedatives, hypnotics, and anxiolytic use disorder. Please take a look at the definition. This is where you have a client who's perhaps using a lot of sedatives, right? Sleeping agents, hypnotics, or anxiolytic, like anti-anxiety medications, usually benzodiazepine and so forth, right? This is going to be a very quick topic. And here is the slide for intoxication. I'm sure you know this. The symptoms are going to be very, very similar to alcohol intoxication, right? The presentation is very, very similar. They do overlap, like slurred speech, unsteady gait, and so forth. And here is the withdrawal, which is going to be the opposite of intoxication. Okay, so the treatment approach really depends on the type of agents and the severity, right? Generally speaking, if this has to do with, let's say, benzodiazepine, and the symptoms are very severe, we can actually give them a reversal agent. So that will be in inpatient setting. Flumazenil is IV a drug that we can use to reverse the effect of a benzodiazepine, and at the same time we need to start tapering them off of a benzodiazepine before we discharge them. If possible, we should finish tapering them off and make sure they're stable. But if that's not possible, if they're stable enough before we are done finishing the tapering process, then outpatient clinic can actually handle that. And sometimes if the symptoms are not that severe, tapering can successfully be done by the outpatient clinic, by the way. And I do that. The way I handle the tapering is that I prefer a long-acting benzodiazepine instead of a short-acting. So the patient was taking, let's say, way too many short-acting, like a Xanax or Ativan, lorazepam, and so forth. Then I will switch them to long-acting, like a diazepam, which is Valium, or chlordiazepoxide, which is a Librium. Instead of short-acting. We talked about that, right? Because there's a huge potential for misuse when you have a short-acting, right? You need to keep taking every 4 to 6 hours or so. Now, my other approach is when I start tapering them off, I usually do 25 to 50% reduction from the initial dose every 1 to 2 weeks over 6 to 10 weeks time frame, and we can stop or delay the tapering if the patient doesn't feel comfortable. Remember, the patient has to be part of this process. and we need to do it in a very slow fashion and make sure the patient is getting the maximum benefit out of this, right? All right, and if the patient is reporting like insomnia throughout the process, we can consider melatonin. I do that a lot, and of course non-pharmacological interventions are very, very important. And here is a summary table for a treatment approach for these agents. All right, number 8 is stimulant, and that will include amphetamine type substance or cocaine and some other stimulants. So take a look at the definition. Well, where are these individuals getting these agents from? Well, amphetamines can be obtained by prescription from their PCP or pediatrician for the treatment of obesity or ADHD and some other issues, and then it can be diverted into the illegal market. Cocaine, on the other hand, comes directly from the illegal market. Of course, it's produced by the coca plant, and usually inhaled crack is a crystallized form of cocaine that can be smoked. It gives you like instant high, if you will. Just generally speaking, for any substance for that matter, the effect on the brain really depends on the speed at that the agent can travel to the brain, right? And that causes intoxication. Harrison Act of 1914 prohibited the sale of cocaine without prescription, and President Nixon declared a victory in his war against drugs. I will let you decide the outcome of that policy, by the way. I don't want to get into politics here. So the mechanism of action for cocaine is very powerful effect on the brain. I know we talked about dopamine, and dopamine is actually our brain's natural cocaine. Okay, that gives us that pleasure, if you will, right? So cocaine prevents the reuptake of neurotransmitters. So if you're going to prevent the reuptake, that means you're going to have increased amount or increased concentration in the synaptic cleft, right? So that creates very powerful effect. According to this resource, effects of cocaine is so strong that sleep, safety, money, love, responsibility, morality, even survival become largely irrelevant to the cocaine user. They actually did an experiment on rats, and they gave them cocaine, and they monitored their behavior, and they noticed that once they got addicted to it, and which was very quickly, by the way, so cocaine is going to hijack their brain and then increase amount of dopamine, and nothing else mattered to those rats. They actually gave these rats option to sleep, eat, or to have sex, or to continue to use cocaine, and all of them chose to use cocaine over everything else. And this is my silly way of making my point. Who moved instead of cheese, who moved my cocaine? So nothing else matters for someone who's using cocaine. All right. What are the effects of cocaine? We know the most common effect, the instant effect, euphoria, right? That's very common with multiple substance use. And you get increased sense of energy. You feel that you're very confident, and you don't need to eat, you don't need to sleep. So decrease appetite, decrease need to sleep. But there are some other physical problems on top of these psychosocial issues. Sinusitis, nasal irritation, nasal bleed. Make sure you assess their, nose, throat and mouth and so forth. You might notice perforated nasal septum, and that's just the mode of their usage, if you will. And then pneumonia, weight loss, chest pain. Unfortunately, most of these users, they die because of sudden heart attack. So it's a big problem. So here is a list of some symptoms for intoxication. So please take a look at it. And here's a list of stimulant withdrawal symptoms, right? It's going to be the opposite of what we just talked about. They're going to be very tired, fatigue, very hungry, and so forth, and can't sleep. Okay, very briefly, a treatment approach for stimulant use disorder. Well, the first one on the list is your psychosocial interventions. We talked about this. Your first line has a counseling, CBT, and so forth. Make sure you take a look at my part 1 of the lecture. And then pharmacological interventions really depends on the type of a stimulant the client is using. And here is the summary table for treatment use for stimulant use disorder. All right, well, number 9 is tobacco use disorders. Remember, tobacco use is the third most commonly used agent worldwide. And here's the tobacco plant. Nicotine is a type of compound that is present in tobacco leaves. There are some other chemicals that are part of tobacco. So nicotine is one of them. So the name of the disorder is a tobacco use disorder, not nicotine, because nicotine is just one of those compounds. Okay. Another thing I want to mention here is, as we know that nicotine is a very, very addicting, right? It's probably one of the most difficult habit to quit, and it's very dangerous as well. We know it can cause cancer and some other health issues, cardiovascular, tachycardia, blood pressure issues, and so forth. And it is commonly used substance. We talked about that. But at the same time, when we talked about not judging people and not adding stigma, we have to be very careful the way we talk about tobacco or smoking, and do not label these patients. For example, never say he's a smoker. That's not nice. We can say you have a client who smokes, right? So be very neutral with your description of your client. And also, I do not want you to think that every person who has a mental health issues, they smoke or they drink alcohol or they use some type of substance, because that's not true. You can have a client with a mental disorder who has not touched any substance, right? And vice versa. You can have a client who is using some substance and not have a mental disorders. Yes, we do see some correlation, and we talked about that as a dual diagnosis, but we cannot have this mindset that, oh, it's their fault, they were doing substance and therefore they have a mental health issues, because that is not always the case, right? That may be true for some individuals, but that is not the majority of the case. So please be very, very careful when we talk about these disorders. All right. Well, first of all, I will not put this lady on nicotine patches. I think she looks great. Okay, so when we talk about tobacco use, people have a lot of options. Either they can have cigarettes, or they can chew tobacco, cigars, pipes. We also have e-cigarettes, and most of them they come as a flavored e-cigarettes, if you will. And unfortunately, their target audience is adolescent population. And people believe that, e-cigarettes are safer because it doesn't carry any smoke, just a vape, and that's not true, right? It carries a similar risk from cancer standpoint of view, and from blood pressure, cardiovascular risk factors, right? So it requires a lot of patient education here. As we know that nicotine is very addictive, so e-cigarettes, they do carry a same risk minus the smoke part. That I understand. All right. While the treatment, unfortunately, it's very difficult to treat a tobacco use disorder, and treatment to treat nicotine is nicotine itself. That's the first line treatment, and we usually offer a nicotine replacement therapy, such as a patch or a gum and so forth, right? So why is this very addicting? What is the role of acetylcholine in nicotine's action? Well, first of all, acetylcholine is considered our brain's natural nicotine. Remember, we talked about natural opioids and natural cannabis and natural dopamine. So here is our natural nicotine in the brain. Acetylcholine is it's a type of neurotransmitter, right? So what happened is nicotine, acetylcholine receptors. Remember, acetylcholine has two different types of receptors, muscarinic receptors, M1, M2, M3, and so forth. And then you also have a nicotinic receptors, right? So with nicotine is going to bind at the nicotinic acetylcholine receptors, and it binds very quickly as soon as it enters into the brain, and within a few seconds or so. And what's going to happen is it's going to mimic, nicotine will mimic the effect of acetylcholine. Brain believes that it's under the influence of acetylcholine, even though it's not a true acetylcholine, it's actually nicotine, right? But it mimics the effect of acetylcholine. So what happens is when it binds at the receptors, nicotinic receptors, it's going to overstimulate some other receptors to release neurotransmitters, such as dopamine, and that's where we get that pleasure or reward, right? And then that's where the addiction starts. The cycle continues, and then it will also release some other neurotransmitters such as norepinephrine, and that's where you feel more alert, right? People do tend to smoke first thing in the morning, right? And because of dopamine and norepinephrine, perhaps that's the reason why we see that effect on blood pressure, like increased blood pressure or tachycardia and so forth. It also will increase the serotonin, so it really helps with your mood as well. And glutamate, remember, glutamate is your excitatory neurotransmitter. Okay, so but again, even though it's increasing all that, and you think you're feeling good, at least temporary, but overall we know that nicotine is a bad, right? Because it does have overall bad negative impact on the body, right? We talked about cancer and some other cardiovascular issues. All right. Here is interesting fun fact, if you will. When someone smokes, nicotine binds to nicotine receptors. We talked about that, right? But over time, these receptors become desensitized to nicotine. So what happened is when nicotine levels start to drop, the receptors gradually resensitize, so basically returning back to their original state. Now that's the point where craving kicks in, because the brain wants the dopamine hit again, right? And research shows that this resensitization happens roughly about 45 minutes after smoking a cigarette. So tobacco companies, they understand this science very well, so they did the math. If the average person is awake for about, let's say, 16 hours a day, because people tend to sleep for 8 hours, right? And receptors resensitized every 45 minutes, so you need about 20 cigarettes per day to keep those receptors desensitized and prevent withdrawal. Isn't that amazing? And that's what we see. A standard cigarette pack contains 20 cigarettes. Now that's not a coincidence. This was intentional. They really programmed or engineered the product to match the body's neurochemistry. Now, pretty fascinating, right? And a little disturbing, to be honest with you, to use the science in their favor, knowing that it's actually harmful to the people who are going to smoke. Okay, now this is an important concept, tobacco smoke as a CYP inducer. Now, recall from our previous lectures, we talked about our hepatic enzymes and some drugs act as a substrate. Remember, substrates are the drugs that are metabolized by cytochrome enzymes, right? And there are some agents that either work as or act as an inducer or inhibitors. Remember, inhibitors are going to inhibit the metabolism or slow down, right? And inducer are going to speed up the pathway. It's going to speed up the metabolism. Okay, so with that understanding, tobacco smoke, not a nicotine, just remember that, please. It's a smoke itself. The tobacco smoke contains this polycyclic aromatic hydrocarbons, PAHs, that is responsible for acting as inducer. So it's not a nicotine. So what happened is when a client smokes a cigarette, let's say, the smoke will act as inducer, so keep that in mind. And we have some drugs that act as a substrate. That means they will be metabolized by these hepatic enzyme, and those drugs are our second generation antipsychotic medications here, such as clozapine, olanzapine. Then you have our respiratory drug to treat COPD, like a theophylline. We also have anticoagulant medication like warfarin and caffeine. They are metabolized through a CYP1A2 enzyme, so they act as a substrate. Now, what happened is when you have a client who's going to start smoking, because the smoking is going to act as the inducer, so this will make the pathway work more faster, more quickly, and that will lead to the decreased plasma level of the drug that they were using. Let's say the patient was using olanzapine, and especially if they are going to smoke heavily, this will result in a subtherapeutic level. So if the patient was taking, let's say, 20 milligrams of olanzapine and their symptoms were very well managed, and now they start smoking, you may see relapse, and it requires to increase the dosage maybe from 20 to maybe 25 or 30 milligram, right, to achieve the same therapeutic effect. And why? Because smoking is acting as an inducer. It's going to speed up the metabolism of olanzapine, which is a substrate. Now, the opposite is also true. When an individual stop smoking, then the opposite will happen, right? This will slow down the metabolism, if you will, and that can lead to increase the drug plasma level. And if you're going to slow down, you're going to accumulate the drug. It's going to metabolize slowly, and you are at risk of toxicity, right? That would be supratherapeutic, opposite of subtherapeutic here, right? So then we need to decrease the dosage to prevent toxic side effects, if you will, right? So please understand, vaping or nicotine replacement, they do not elevate. It's the smoke that matters, not the nicotine. So people who are on nicotine replacement, like a gum or patch, that does not have effect on these substrates. So very, very important concept. Okay, here's a list of symptoms when the client is going through tobacco withdrawal. I'm sure you know this. Mood is going to be very irritable, frustration, anger, anxiety, can't concentrate, and so forth. Okay, so this is the tobacco use disorder treatment summary table. Just take a look at the main receptors. We talked about nicotine acetylcholine receptors, and usually we treat this as outpatient. Here's the psychotherapy options. Now under pharmacology options, we talked about first line as a nicotine replacement therapy with patches, gums, and so forth. And also we have varenicline, which is Chantix, and that we can use. Patients tends to use this for a couple of weeks, months, and unfortunately, if there's any new trigger or stress, they unfortunately go back and start smoking. So make sure we assess them more frequently, and when they start these options, I recommend to use it at least for 3 months before we say that, hey, the treatment is not working. Now, second line treatment is we have bupropion, which is actually an antidepressant medication that works on two different neurotransmitters, norepinephrine and dopamine. And these are dopamine reuptake inhibitors. So you will see the increased concentration of a dopamine in synaptic cleft. So that's one way of getting our dopamine from this agent instead of getting dopamine from nicotine, if you will, right? Now, please do not get confused with this agent, bupropion, with buprenorphine. Remember, buprenorphine was agent for opioid use disorder. However, bupropion is an agent which is antidepressant for tobacco use disorders. These are two different agents. They do sound the same though, but these are two different agents, so make sure you do not get confused. All right, number 10 is unspecified, other, or unknown substance. So take a look at the definition. So what are those other agents or unspecified or unknown agents? Well, unknown would be the one that we don't know, right? Maybe we are not aware of those agents, or we don't know the description. It's a chemical that they ingested and we don't know, right? Unspecified, anything that does not fall under any of the category that we have talked about so far. So for example, steroids, NSAIDs, some Parkinson medications, nitrous oxide, and so forth. Just take a look at it, please. Here is the treatment summary for that. It really depends on the type of agent, right? Okay, so there have been some attempts made to develop a vaccine for substance use disorders, but so far none have received any approval for use in humans. Some early clinical trials looked pretty promising, but in real-world settings, for example, helping people to actually quit smoking or not to use cocaine and so forth, they really didn't beat the placebo. Now researchers are exploring new approaches like using virus-like particles and even AI designed haptens. It's an exciting time, well, at least for me, because I have always seen vaccines as life-saving tools and not a political battlefield. So let's see what happens in near future. Okay, very briefly, I wanted to introduce a point that is it possible that the urine drug test that you have in front of you is a false positive? The answer is yes, that's possible, right? That's why it's so important to listen to your patient, make sure the story is matching, and especially if the patient is on using these agents for a long time frame or maybe in a higher quantity. It's worth having a discussion with the patient. So it's possible that antidepressant agent like a Wellbutrin can cause a false positive for methamphetamine. Also, your SSRI, Zoloft, sertraline can cause a false positive for benzodiazepine. NyQuil can give you a false positive for methadone. Valium can give a false positive for alcohol. that's your benzodiazepine. If the patient is taking amoxicillin or NSAID, false test positive for cocaine is possible. If the patient is taking codeine, they may have a false positive test for methadone or PCP. So I think it's important to keep this in mind. You do not necessarily need to memorize these agents, but it's a good information to know. So that was a substance-related disorder. We covered 1 through 10. This is your non-substance, and there's only just one example, gambling. And here is the definition for that. And the pathophysiology is very similar to substance use disorders, where you see increase level of dopamine and the cycle continues. It's a very similar approach. Treatment, non-pharmacological interventions first, like a CBT, patient teaching, involve the entire family. Of course, gambling does affect the entire family, and plus minus SSRIs. And there is a helpline available as well. And here is the treatment table for non-substance use disorders. And I do want to very briefly talk about some other excessive behavioral. They are not a part of the criteria yet. It requires a further research and more data collection, and we'll see what happens in the future. But these topics are internet gaming, behavioral addictions, with the subcategories of sex addiction, exercise addiction, or shopping addiction, especially nowadays with everything is online. At this point, we don't have enough evidence to establish any diagnostic criteria, but we'll see what happens in the future. But it appears to be that there's some impact on mental health. All right, well, I think that's all I have. I hope you have better understanding of this topic now. I understand this was such a long lecture. I do apologize for that. As usual, if you have any follow-up questions, please do not hesitate to contact me, and I'll be back next time with a different topic. Until then, take care. Goodbye.